The bunion surgery has, I think, several goals. And first of all, this is a game of millimeters. Unlike when we're in the rear foot and ankle, where we have a lot more room and places to make mistakes, this is a very tight area, very small amount of bone to deal with, and there's not a lot of room for errors. This is a game of millimeters, as I like to say. So what are the goals of bunion surgery? Well, I think the first goal, it has to feel good, right? They have to be out of pain. That's what they came for. That's what they wanted. And so the pain has to be gone. The second goal, I believe, is has to function well. Always nervous about a stiff first metatarsal phalangeal joint after bunion surgery. So I believe that these not only have to work well, but feel good as well. And the function is important. We know that if we don't have good post-op range of motion, we're going to get complaints of either a floating toe or sesamoiditis from lack of plantar flexion. And third of all, I believe they have to look good. Cosmesis is the difference between happy and satisfied patients. If we look at the patient on the left, I don't care how good that feels and how well it functions. She is not going to be happy. And from day one post-op until the day she no longer comes back, you're going to get the same question, isn't my toe supposed to be straight? And if we look at this case, look at the second toe, that's going to lead to a hammer toe because you failed to correct the hallux valgus deformity of the bunion. And so this has to not only feel good and function well, but I believe they have to look good as well. And cosmesis is part of the issue for these patients. Procedures for bunion surgery, well, there's a plethora. There's just dozens of procedures. But basically, if we break it down into three kinds of procedures, there are distal metatarsal osteotomies, and I've included the Aiken on this because I think the Aiken is kind of a sort of a distal metatarsal osteotomy. There are proximal metatarsal osteotomies, closing and opening base wedges, and arthrodesis procedure, either at the first metatarsal phalangeal joint or the metatarsal cuneiform joint. But these are our choices of procedures when we look at that patient and decide what are we going to do to them. To that point, this is what influences our decision-making. Certainly the patient on the right had poor decision-making preoperatively by their surgeon because this is not a result that the patient's going to be happy with. We see shortening, we see continued hallux valgus, we see continued intermetatarsal angle with bunion deformity. So when we're making that decision, we have to look at intermetatarsal angles, hallux abductovalgus angles. We have to look at the first metatarsal length, and that will determine what we can do and what we should do, whether we have to grasp. Tangential articular set angle is not something that's commonly known and something I discuss with my residents. It is the angulation of the articular cartilage of the first met based on the bisection of the second met. The proximal articular set angle has never made a lot of sense to me, and studies kind of show that there's a lot of variability because you're basing angles on deformity. We're going to structurally correct the first metatarsal because it's deformed. So basing angles on deformity never made sense to me. The second metatarsal is constant. We're not revising the second metatarsal. So when I look at the articular surface of the first met, I want to see how that's going to line up with the bisection of the second metatarsal, and that's the tangential articular set angle. The condition of the cartilage. We talked about range of motion before and function. Is the cartilage good enough that we can do a non-arthrodesis, or should we look at arthrodesis procedures to fix the patient's deformity? Sesamoid position. The next two parts, obliquity of the proximal phalanx and asymmetry of the distal phalanx. Sometimes we can't correct out the deformity at the distal phalanx, well, oftentimes. So we're going to do a cheater Aiken at the proximal phalanx, and I'll show you that later on down the line on how we can correct these deformities. And then the mobility of the first metatarsal cuneiform joint. If I have a hypermobile first ray, regardless of what the intermetatarsal angle is, I'm going to lead more towards a lapidus or a first metatarsal cuneiform fusion. And with any procedure, you have complications. And again, as I said, this is a game of millimeters. A few millimeters one way or another leads to a significant complication. If you look on the picture to the right, I've done a reverse Austin osteotomy, and then I've done a tightrope, but I had to undo the correction that was done on the first by the first patient. And by doing that, I was able to realign things. So again, just a few millimeters one direction or another can lead to significant complications. And as we talked, loss of motion, floating toes, or painful sesamoids. And as we all know, that once that motion on the first metatarsal phalangeal joint starts to, we start to lose that motion, it becomes more and more difficult to gain it back.